Is that okay?
Yes, David, we're live.
Okay, thank you. Okay, Ian.
Right, thank you very much. So welcome everybody. First, whilst not in any way intend to be rude, but I know that sometimes I'm certainly not an IT expert. I know that bandwidth can sometimes not be good when everyone's got their cameras on. So could I suggest that everyone stays on mute? That will hopefully help to keep noise interference down to a minimum, and suggest that everyone puts their camera, closes their camera off. I'll try and keep mine on most of the time, but when anyone is speaking, would suggest that they put their camera on so we can see them. But if everybody else turns their camera off, not because I don't want to see everybody, but it might just help to make meeting to work a bit more smoothly. So I can see people doing that. So thank you very much for that. So I've got the agenda up. So welcome to our Health and Wellbeing Board this afternoon, Microsoft Teams. Apologies therefore at the moment provisionally from Councillor Yvonne Davis. I presume that, is it Claire who's taking notes for us at the moment? Yeah, I can see you, David and Claire, that's great. So bring up that. So have we got any other formal apologies, first of all, other than at the moment from Councillor Davis? So share your Okay. Any other representative from Health Watch on his behalf? I can't see anything on the people here.
Yeah, it's Lexi, Health Watch Manager. Okay.
Chair, oh, that's a message from Toby. That's fine. No, so we'll get Toby in as soon as we possibly can. So that's apologies. Any declarations of interest that aren't already on the list, or people want to make any declarations of interest? Just out of interest for myself, I can actually point out that currently I'm no longer a GP partner of Your Health Partnership, and therefore there's no potential conflict of interest between contracts that Your Health Partnership may or may not have with the council. So I just could note that. Assuming, I'll say that if everyone has got any conflicts, they want to put them in the chat box. Just pause for a moment. Can't see anything there at the moment, so I assume there are no more conflicts of interest to be mentioned. We quickly go through the minutes of the last meeting. This was quite a while ago, so I'll go through those very quickly. This is a meeting that took place on the 16th of January. Actually, maybe before that, do I need to just go through all the various regulations? They are in the minutes, so there's a whole list of things that we should do, shouldn't do, and not to speak, and when to speak, and so on. So we take those all as read. Pause for a moment there. Okay, that's great. Let's take those as read. Moving on to the minutes very quickly. So minutes 16th of January, list of attendees, page 7, page 8, page 9, update, page 10. And that was actually the end of the meeting. So are we all happy that those minutes are a true record for those who are there? I'll just pause for a minute for any comments. Suggest that unless you've got a specific comment, remain silent. And I can't see anything on the chat box. I'll take that as indication that yes, the minutes are a true record and agreed. That takes us back to the agenda. And I think the first one actually is going to be Toby, but to get back to the agenda. So actually, first of all, can I just maybe suggest that Toby's down second? Can I suggest that we move Toby up first so he can get his item, and it allows him to leave and get on to other business? Is that okay?
Yeah, I'm very happy to listen to Lisa, because I think our two items are somewhat interrelated.
Okay, in which case, thanks for that, Toby. So therefore, Lisa, do you want to come on board? So COVID-19, sample positions, update and epidemiology. Over to you, Lisa.
Thank you, Dr. Sykes. I'm going to share my screen, and hopefully you'll be able to see those slides. Can you see them okay?
I can certainly see them, Lisa, so hopefully everybody else can too.
Lovely, that's good, thank you. So I'm going to provide a very brief overview. Obviously, there's so much data I could present to you, and I've tried to be selective as best I can. So if we firstly consider the numbers of confirmed cases, what we've obviously done for purposes of comparison there is presented a bar chart of the COVID-19 confirmed cases per 100,000 population. And as you can see, in terms of the Black Country, Wolverhampton and Walsall are ahead of us. Samwell is riding somewhat ahead of the West Midlands and England averages, which are also similar to Dudley. So we're sort of in the middle of that pack, lower than Wolverhampton and Walsall, but slightly more than West Midlands in England. Now, I hasten to add, these are confirmed cases, so obviously they are to some extent a product of infection rates, but they're also a product of testing activity as well. If I move us on. This shows our cases over time, and it really shows what we would refer to as the EPI curve, the epidemic curve for the Black Country and also England. Essentially, those coloured lines, except for the blue, which is England, plot the Black Country local authorities, and you can see there in terms of confirmed cases, we peaked really around April, and we've been declining ever since until I would say probably the end of May, where the number of cases have remained steady, so we're not going down anymore. And of course there will be discussion, I'm sure, during the meeting about the possibility of a second wave in cases, which is a normal feature of pandemics, but also something we expect due to the lifting of social restrictions. Moving on to really a more valid outcome in terms of the impact is, of course, deaths relating from COVID-19. You can see there the Black Country again plotted against England and Wales. Sandwell has sadly seen 339 of its residents die directly due to COVID-19. And again, we are below Walsall and Wolverhampton, but ahead of ahead of Dudley, and also, of course, England and Wales. This is probably the most important graph of all in terms of demonstrating the whole impact of the pandemic in Sandwell. As most of you will know, we can't really just count the deaths that are directly attributable to COVID-19. There are a number of deaths that are indirectly thought to be caused by the pandemic. Most notably, the NHS, our NHS colleagues have been aware for some time that people have maybe not been reporting symptoms or seeking healthcare when we would want them to. And of course, NHS, together with ourselves, quite rightly mounted a campaign to try and get people to seek help for symptoms, even though there is a pandemic on. People were obviously staying away for fear of becoming infected or maybe burdening the health service. But as you can see there, the blue blocks are the all-cause deaths excluding COVID-19, and the orange blocks on top of them are the deaths caused by COVID-19 directly, and obviously the two combined represent all causes of death. Along the bottom there you have the weeks. It's probably too small to see, but over here is week 11, which is the 13th of March, going all the way through to week 22, which is the end of May, and that's as far as ONS data takes us to. ONS data is, of course, the best source of death data because it's comprehensive. It does combine hospital deaths, care home deaths, deaths at home, unlike other sources of death that you might see reported in the news or on the government website. So this is really the sum total of the impact, and you can see the impact really peaked around week 15 and 16, which was the mid to the end of April. The red line shows us the all-cause mortality rates for the previous 5 years. So that's where deaths would be in a normal year. And you can see the last week of data is the first time since the start of the pandemic that it's come down below that weekly 5-year average. Now, moving on to care homes. I think I've said it before to some of you, but probably some of the most difficult weeks of my career so far have been during April and May, when we were facing the number of outbreaks that we were in care homes. You can see there that the number of deaths per day actually rose up to 2 and towards 3 in some cases. We're now back down to a lower level of care home deaths, and that's a testament not just to all the professionals who've been working to support care homes across several different agencies, but also, most importantly, I think the care home staff themselves. In terms of comparing deaths in care homes across the areas, Samwell, I would never refer to the situation in care homes as a success. You can't ever think in those terms, given the number of people we lost and the families left without their relatives. But it's certainly the case that in Samwell, the number of deaths in care homes per 100,000 population was lower than the rest of the Black Country and England as well. So we're still looking into that data, but it's been fairly consistent for a while now. And I'll stop and pause after this slide, just looking forward. I've got more slides on BAME groups, which we're going to come to later. But the things we have to think about going forward, I'd say, are 4 things that we are going to put in place, and these are just 4 out of many, as we prepare for a second wave. There will be a second wave. There's little point in speculating about whether there will or won't be a second wave of cases. It's really just a question of how big it is and how close it comes to challenging the capacity of our partners in the hospitals in particular, but also across health and social care. The things we're putting in place, we've expanded our outbreak response cell, which is my health protection team that respond to outbreaks, to be able to deal not just with care home outbreaks, but schools, workplaces, anywhere they happen really. We're working with Samwell and West Birmingham Hospital Trust on the creation of a new community swabbing service, which is really shaping up to be, well, I would say this, I suppose, but one of the best we've seen, certainly that's been developing across the areas. We are ramping up the number of risk assessments we're doing. I must personally have spoken to about 40 to 50 head teachers in the last 3 weeks, which has been a real pleasure, actually. They are amazing people who have really adapted to the new challenge that's facing their schools, and we've been doing risk assessments to help them prepare to open up to more children, and of course with various retailers and other settings. And finally, we are looking again at our communication strategy. We had a relatively simple message up until recently, which was stay home, and that was nice and easy to communicate. Things have become incredibly complex recently, not least this morning as I've been trying to explain to Samwell residents the new concept of a social bubble. So we're going to have to look at communications as a system again, and later I'm going to propose the formation of a community engagement board involving members of the Health and Wellbeing Board to make sure that we continue to talk to each other about how we should be talking to our residents. So I'm going to pause there, Dr. Sykes, and unshare my screen.
Thank you very much, Lisa. I think that was a really helpful summary. And I think it's also, I'd like to just put on record, sadly, like often in times of crisis, what a fantastic effort of joint working, both between health and local authority. Also, that's primary care and hospitals. I know the work that Sally Roberts has been doing, leading across the Black Country, working with you. And although Warsaw's a little bit of an outlier, overall, despite the Black Country being one of the worst hit areas for COVID, it's really testament to that fantastic work that our overall relative deaths in care homes is below England's average, despite the fact that number of cases per 100,000, we're one of the worst hit in the country. So although it's very sad that so many people have died, it could have indeed been far, 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 far worse. So thank you for that. Before Toby comes in, I appreciate time is very tight, but are there any specific questions that people want to ask Lisa? Either use the hand up or put your message in the chat bar, and maybe Lisa might take 1 or 2 questions before we then bring Toby in. Okay, there's a pause there. Maybe on that basis, if Toby, you want to come in, there may be questions that people want to ask either you, Toby, or Lisa, possibly after your presentation. So on that basis, do you want to come in, Toby?
Yes, my presentation, despite advertising that there would be one, turns out to be me sat on a chair talking. So I do apologise. I did think those slides were very good. I'm going to talk about 2 things, and I am going to join them in. So I'm going to say something about COVID as we see it as a healthcare provider, and then something about the integrated care partnership. And given that a lot of the work there, as colleagues from Black Country Health and others will know, Stuart, for example, has been a conversation about COVID. The items do link. Perhaps first, just to add something to the comment on all-cause mortality. What I think some people had anticipated is that with a big fall in people coming to hospital for non-COVID diagnoses, and we have seen a huge fall, that actually a number of people who died from other things in hospitals would fall. That's absolutely not the case. As a hospital, for example, and I'm thinking City and Sandwell here, not just Sandwell, about 110 people a month typically die in our care, the vast majority expectedly. That number hasn't fallen. So effectively, the people who are not coming for care are those, I'm not saying this is right, but are those for whom mortality as a harm outcome perhaps wasn't the principal concern. Clearly, all of us are worried, in addition to the second wave that Lisa mentioned, about sublimated demand, people staying at home with potential cancer symptoms or sickle cell or lots of other things. And that's certainly something as an ICP grouping and with GP partners there, we want to focus on and make sure we're looking at that in quite a quantified and thought through way. Back to the care homes, obviously as a trust, we reorganised all of our community teams at the outset of the pandemic to support care homes. And I think that's then been picked up, as you say, Chair, by other parts of the Black Country. I need to be clear that the relatively low level, tragic though it is, of care home deaths compared to others is not because people in care homes are being admitted to hospital in larger numbers. The number of care home admissions and readmissions this pandemic versus the same period in the prior year is pretty much flat. So whatever is the cause, it's a different cause to that. A bit more than 370 people have died in our trust from COVID over the course of the pandemic. I say a bit more because I'm always a bit nervy about what numbers the government has announced, and it would be important for the board, for example, to be aware that at one point 1 or 2 deaths were announced rather more than once in the process. Like Lisa said, we're seeing a falling away and now a plateau. What in practical terms that means is we've gone from having 8 to 10 wards of patients with COVID-19 to having probably by this Saturday 1 ward with COVID-19. You will have heard a lot of mention in the media about nosocomial infection rates, or cross-infection as my mother would call it in Yorkshire. We've studied that, we've published data on it. It's something people could ask us about if it's useful, or could study our board papers if you have a particular interest. Across the UK, the sort of government published anticipated number, that's not saying it's okay, it's just saying it's what happens, is in the order of 20%. At the moment as a trust we're rather below that, but it is important probably to be clear for the board that there are some particular issues within Sandwell Hospital, as distinct perhaps from a Victorian hospital like City, and those issues are partly physical space, and partly we have almost no discrete ensuite bathrooms. So that has led us to manage COVID infection by ward rather than by side room. And we're doing everything we can to manage cross-infection rates. We have done relatively well with PPE in the eyes of our staff to date, and clearly one of the challenges for us, as for other people on this meeting, as we go into something the NHS wants to call recovery, in other words, treating lots of people who don't have COVID in the way we would have done before, you can imagine that that will eat into resources like PPE. And then obviously announcements like Mr. Hancock's announcement about face masks and face coverings has a similar impact. For much of the pandemic, we've provided with pleasure a PPE resource to other partners round the table, and we provided with slightly less pleasure but fellow feeling to large neighbouring hospitals as well. So that's where we stand in terms of patient volume. Testing wise, we're still doing a lot of antigen testing, and for next week we open up antibody testing through the trust to partners, many of whom are around the table. I do hope that goes well. It's bound to have some teething troubles. In our antibody testing, and of course we don't really know what the antibody in truth in practical terms means, but antibody infection rates are running at about 20%. I've just seen some data this morning on temporary staff, in other words bank workers, and the antibody pickup rate there is markedly higher. So not today, but at some point we will have a think about that in terms of where we've got, if you like, itinerant workers who go through a number of care settings, whether that creates a different rate of exposure and therefore perhaps a higher antibody rate risk or positive, I suppose. Outbreak-wise, echo the comments made by Lisa. There clearly will be a second wave. The exam question is almost, what is its nature? Is it a community wave? Is it the mental health wave? Or will that wait for the third surge? Or is it more of what we saw before? We are ready to expand as we did before, and we're confident about that. We are working, and I think this will be a theme in the ICP chair, on the idea that you work backwards from winter, because when we certainly will be very challenged for what bureaucrats call capacity is when we're seeking to manage an NHS winter at the same time as managing a second or a third or a fourth wave. In response plan terms, and then I'm going to gradually pull up, we will get back to treating the volume of patients we previously were before COVID by the end of August, unless the second wave hits. There are some exceptions to that, because for a number of procedures one now has to have a sort of 20-minute downtime for some form of decontamination between procedures. So that will certainly apply to some orthopaedic and ophthalmic surgery, but beyond that, with the exception of endoscopy, we are tooling back up. We have not accepted and won't be accepting government advice to readmit visitors in normal numbers from Monday, because we are concerned by the sort of positional R rate and other indicators that suggest maybe we need to wait locally a little longer before bringing the general arrangements back into the institution. As an ICP, we are focused at our monthly meetings on thinking together about what we might do on COVID, and some of the things Lisa mentioned are germane to that. And we meet on Tuesday and have not in any way given up the notion that the priorities that were set by the ICP, which I'm going to assume have been briefed to the Health and Wellbeing Board previously, are still things we're working on. And I guess that's germane to the poverty and inequality agenda that so obviously sits behind some of the harshest stories in the pandemic, and a lot of those ICP priorities are about tackling those inequalities and seeing what we might together do about them for both children and families and adults over coming months and years. That was, I think I was asked to share, as it were, how it was going. That's what I wanted to share, Chair.
Thank you very much, Toby. I think on that, first of all, to thank you all for the work that your trust has done, both supporting them not within hospital, but also within primary care. I think it's also fair to mention that within primary care, we're also now moving into what we hope is restoration and the new normal. So things will never get back to the old normal, but we're starting to do a lot more routine work now within primary care. However, still maintaining sites where surgeries, what we've called the green sites, where patients will not be allowed so that our high-risk staff can work. So we're still not opening every surgery yet, although we hope more surgeries can open, and we are still maintaining our red site surgery at Parsonage Street, simply so we've got a centre where our very high risk suspected patients can be seen in order to try and protect the rest of our community. So the ICP, of course, is helping to make sure that we're working towards that process of restoration. So thank you for that, Toby. Are there any, obviously we have very much again of time, any particular questions or comments for Toby before Toby leaves us? So just pause for a moment there. Again, I think there'll be plenty of opportunities during the meeting for people to pick things up or bring back comments to us if necessary. So, okay, message, comment, Joanne Hadley. Joanne.
Hi, Toby. Question I want to ask. These home testing kits, how reliable are they?
Oh, well, I think you may be better asking your doctor rather than the chief executive. So can I defer that to the chair?
I'm certainly happy to. Well, in my instance, and Lisa might comment that the test is only as good as the operator. I suspect that the home test, I mean, having actually had a COVID test done myself, is my concern is that it's a very unpleasant test to do. And I'd be concerned that many of the home tests may not be done properly. If they're not done properly, then it will give a false negative. So I think the current estimation is that about a 70 to 75% accuracy rate. So potentially 1 in 4 COVID swabs will test negative, but that might be an inaccurate result. Is that fair assessment, Lisa, do you think?
Yes, absolutely spot on. It's the mechanism of gathering the sample that gives the false negative if there is one. The actual test, the PCR as it's called, is very reliable. What we can say is a positive test will normally be positive. It will be proof positive, but there are some false negatives, and one fear is that home testing creates higher levels of false negatives, but we don't actually have a lot of data on that.
No, I would concur with that. So I hope that answers your question, Joanne.
Yes, thank you.
Okay, I can't see anything else in the chat box, so I'll move us on. I say aware of time. I know that Lisa's got quite a few comments anyway, so in fact that's Lisa. So thank you very much, Toby. If you wish to leave us, then that's fine. We've got Stuart and Lisa now talking about test, track and trace within Sandwell.
Lisa, do you want to start us off?
Thanks, Stuart. I'll be very brief. So it's actually test and trace now. They dropped the track because they thought it was too Orwellian, apparently. And
was it test, trace and isolate even? Is that the other buzz term?
Yeah, so they took test and trace and then they added the isolate. In public health, we've been calling it contact tracing for about 150 years, ever since John Snow found that water pipe was a bit dodgy in Soho. So it's something that public health are well used to. What the system isn't used to is contact tracing on this scale. So just briefly, test and trace or contact tracing is how we separate the infected from the non-infected. In the absence of any mass lockdown, the only way we can navigate ourselves safely out of social restrictions is to identify people who are positive promptly with testing, and the emphasis on the promptly there, then get in touch with them and ask them to tell us their contacts. Who have they been in contact with, usually in the previous 48 hours, depending on when symptoms arose. And then what we will do is contact the contacts and ask them also to self-isolate. So that's how it works. Easy to say, not very easy to do. In terms of the local model, we're ready and in fact are already doing it in the context of outbreaks. The national system, as you will all have heard, has had a number of teething problems, which I guess is to be expected. In a nutshell, looking at the data, we're doing a fair bit of testing, but we're not doing enough tracing. So I think that's probably the basics, Stuart, and I can answer any questions on the methodology later, but shall I hand over to you now?
Yeah, I think from my perspective, when test and trace was kind of first announced, it was associated with an app, and an app that would kind of automatically identify individuals who had potentially been in the vicinity of 2 meters of an infected person. And we were really concerned that we would have significant numbers of people who work in adult social care receiving a notification from the app advising them to isolate. And in the context of that, we were concerned that that might significantly deplete our capacity in adult social care and across healthcare. In the context of that, one of the things that we've done is at the ICP, we've put together a simple survey that has gone out to all partners. And we've asked our partners to advise us that in the event that we see significant numbers of our workforce across health and social care depleted, what might we do as a system? So what support could we provide? We used that a scenario of a care home or a number of care homes across the borough having depleted staff numbers. So what could the partnership do in relation to support? So we're going to collect that up, and it's quite helpful that we've had some of the national delays, because it means that we're in a position to formalise our kind of contingency plans and around how we will deal with potential significant reductions in the workforce. But I think as it stands in relation to how kind of Lisa's conveyed the position, we haven't necessarily seen any real impact for us as we were originally concerned around. And that's it from me on this one.
Sorry,
Karen, Lisa, yeah, carry on.
Just one important point about the effect in terms of healthcare and social care settings is the protocol. But by the way, I think the app is coming. It's just got whatever you call app problems. It's got some of those. The protocol states that if a health or social care worker is wearing PPE at the time of contact, then they're not considered a contact. So one of the big things we need to get right is to make sure, for example, in a care home, that of course staff are wearing PPE when they're in contact with those who may be infected among the residents, but also that they avoid having sort of group contact together when they're not protected by PPE, say lunch hours, etc. Because if one person is confirmed positive and they're not protected by PPE, that could mean the rest of that group have to self-isolate. So that's a message that we're getting out to care providers at the moment.
Thank you, Lisa.
That's great. Thank you very much. I think the important thing is that if we're going to try and, well, reduce, I think we accept that, reduce the second surge, then tracing and testing is absolutely vital. We've got to find all those people, particularly I think in this, I mean, if people have got flu, for those who aren't medically proficient, if you've got flu, by and large, everybody with flu will have symptoms. The problem with COVID is that we know that at least 10% of people who are COVID positive, they are therefore infectious, are completely asymptomatic. And that's the danger, that we've got people walking around with COVID who have no idea that they've got it. Hence the test and tracing is so important, because we've got to find those people who could have COVID, who don't know they've got it, to try and stop them spreading it to anybody else. So that'll be just a comment there. So thanks very much, Lisa and Stuart. Any questions particularly for them regarding test, trace and isolate, which of course, as we know, has been something around, it's been for ages as the old contact tracing system? If not, I'll stop there. I think actually that then nicely brings us into the next item, which is now shielding. Of course, those of our very high-risk patients who've been keeping at home, not quite under lock and key, but wanting to avoid them being exposed. So if you now move over to, it'll be Alison and Stuart and Mark, looking at shielding and also how they've been helped by the voluntary sector. And of course, the voluntary sector have done an absolutely fantastic job of helping to support the health and social sector. So over to Stuart, Mark and Alison. I'll leave it to you to decide who needs to come in.
Thank you.
Thank you.
Just to add that Leslie Hagger will be contributing as well, so it's a bit of a quadruple act really. So Leslie will be talking in the context of shielding children. I'm just going to share my screen, and people will kind of go through their particular slides as we kind of work through it. Whoa. Oh no, 1 second.
Great, I can certainly see that now, Stuart, so hopefully everybody else can see it.
Yes.
So on the 24th of March 2020, the government issued shielding guidance. That was in relation to some 1.5 million letters. Someone else has started their presentation. What have we got on the screen at the moment?
It's just the three of you now, so the presentation was there, it's just disappeared. Oh, here we are, we're back on again.
Okay. So just to start again, so on the 24th of March, the government issued shielding guidance, and that related to 1.5 million letters that had gone out to people who are identified as clinically extremely vulnerable. And in effect, those individuals were told that they needed to self-isolate for the forthcoming 12 weeks because due to their health condition, if they contracted the infection, there was a significant risk to their kind of health. In the context of that, the guidance set out a specific role for local authorities in the context of food delivery, the provision of medicines and support to pharmacies, and how we as local authorities kind of support people around their social contacts, so how we engage with them through our voluntary partners to ensure that we're reducing isolation as part of this. From a Sandwell perspective, the initial shielding list included about 8,000 people. The current shielding list is now 12,618, but this fluctuates daily as you would envisage. As the health service kind of starts to be engaged, we will have people who are newly diagnosed with different conditions, which places them on the shielding list. So 12,618 local people are shielding as it stands. Whilst we recognise in Sandwell that those shielding individuals are really vulnerable and susceptible to COVID-19, we also identified that there was a whole host of other people in Sandwell who were equally as vulnerable. They might not necessarily be on the shielding list, but they had an array of different needs that meant that they were vulnerable. So we used data from across adult social care, reps and benefits, neighbourhoods and communities, and we identified around 10,000 people who we felt were in some cases just as vulnerable as the shielding group. What that meant is that in Sandwell we identified that we had a combined shielding and vulnerable list of 23,227 people. In order to support that group of people and our wider population, we established a number of teams. So we have welfare agents that have been calling people proactively. We have a practical support unit, which has been the mechanism that's enabled some of the food deliveries, which Alison will talk to you about in a bit, but also some of the practical elements of medication and finances. We established a food hub and we engaged significantly with our voluntary sector partners. So you're going to hear a bit about, in particular, the food hub and the voluntary sector work from Alison and Mark as we kind of work through this. So in Sandwell, what we did is we took forward both a proactive and a reactive approach. From a proactive perspective, we put letters out to the 135,000 households in Sandwell, and we did that twice. In those letters, we set out to people the support that the council and its partners had available to people, in particular those who were self-isolating, alongside people who were shielding. And we provided people with contact details of how they could get in touch with us if they needed to, and links to government guidance in the context of COVID-19 and self-isolation in particular. On top of that, we had some data from our colleagues in the CCGs, which allowed us to identify over 28,000 people in Sandwell who were over the age of 70 and registered with a local GP. As it stands, we have contacted proactively over 20,000 of the 23,227 people that we identified on our combined shielding and vulnerable people's list, in order to make sure that they're doing all right, they're not struggling, that they have everything they need in the context of potentially self-isolating. We've seen quite a low number of people within that group that have actually needed support from us, with only about 6% of the people we've contacted needing support. Running in parallel with that, we've obviously got our reactive response to people's inquiries. So as you can envisage, putting all those letters out to households in the context of the generic one and the over 70s has meant that we've had quite a considerable amount of calls from local people. Some people just telling us that they're all right and they don't need any support. Others asking for somebody just to check in on them every now and again. On top of that, from the shielding list, we get 3 sets of data each day. And that has been quite an adventure in itself in the context of the accuracy of some of that data and the consistency of that data. So, as I mentioned earlier, new people are added to the shielding list every day, which that comes through to us, so we make contact with them. People on the shielding list, when they get a letter or advised by their GP or their consultant, are asked to go on a website in order to register any support that they may require. So we get regular requests from people who have registered for support, and we contact them accordingly. We also get a data set through that includes people who the Department of Work and Pensions have tried to contact because they've not registered on the website. When the Department of Work and Pensions can't contact somebody and they've done 10 calls to them, they pass those through to us. Equally, if we've got people who the government can't deliver their food parcels to, those come through to us as well. So we have a bit of a job trying to get in touch with those people. So as well as calling them, we have groups of staff who we send out door knocking, we post cards through people's doors, so that we've got that kind of absolute assurance that we haven't got somebody left without the support that they need. So on the reactive side of things, overall, we're seeing between 25 and 30% of people who are contacting us end up with either some form of intervention from our practical support team, and a very, very low number. There's only about 160 people who've needed care and support from us from an adult social care perspective. Leslie, do you want to talk about children's shielding?
Yeah, can you hear me?
Leslie, I'll just put your slides up for you.
The slide's there, thank you. No, the slide's already there, thank you. We rely on all of that good work that's happening that Stuart has just described in terms of going through all the data to get the daily report that comes through about children that are shielding in the borough. A lot of children, just under 700 shielded children, many of whom are children with disabilities or long-term conditions. And we include a review of all of those children daily as part of the vulnerable children group meeting. So similar to the situation in adults that Stuart's just described, a much broader group, wider group of children, and looking at the needs of these children within that wider vulnerable children group. So we make contact with the families, and that contact has been facilitated through a number of different agencies, depending on who seems most suited to the particular family circumstance. It could be the social worker, it could be a school nurse, or local authority officers, education officers, schools. And a whole range of support has included food hub, food vouchers, nappies, etc. But also some additional things to really support families' emotional health and well-being. So play resources, games, and activities that families can do at home, and signposting to other sorts of support. And it's quite interesting, some of the feedback that we've had for families about how helpful it has been to have support to financial advice in terms of dealing with debt, etc., that they might not normally have thought about. So there has been some really interesting and quite positive spin-offs for many of these families. We're leaving a contact email with families when they no longer need support, in case they should need support at some point in the future. And in terms of links to voluntary sector provision, lots of our providers of chastity clubs, holiday schemes for disabled children, etc., are offering virtual support. And I thought it would just be really nice to put a little quote in the bottom of here. Sandwell Parents for Disabled Children have delivered all sorts of fabulous activity packs. And just this quote here from a family who called themselves Family M. We'd hit an all-time low, but the pack soon turned it around. We had some much needed family time together with no gadgets in sight. We feel we can cope with a few more weeks now of this crazy world, and thank you will never be enough. And I think that's a really powerful statement from a family about the support they've had from a voluntary sector organisation. Thank you.
Alison, do you want to talk about the food hub?
Thank you, yes. So as has been mentioned by Stuart and also by Leslie, we established a food hub at Tipton Sports Academy at the end of March, and 60 staff from all directorates across the council have come together to work at the hub, along with members of the fire service, some of our taxi firms, particularly those who normally are contracted with us to work with the schools, and also the Albion Foundation. And they're working with us to help purchase food, the admin, particularly packing of boxes, and also deliveries out to people. What we've been doing is we've been purchasing the food from the authority, which actually was no mean feat at the start of this. You know, we weren't getting large supplies. People were restricting the amounts that we could buy, and it did take a lot of the team to go out and actually just get the purchases in and then arrange orders with local supermarkets or wholesalers and directly food manufacturers as well. But we've also been getting large numbers of donations from local supermarkets, restaurants, shops and firms. And at Easter, we had hundreds of Easter eggs donated, which was sent out to children and the elderly as well, actually. I think they quite enjoyed a little bit of chocolate at that time as well. In addition, we've been putting sanitary products or baby milk and food where that's appropriate. The initial offer was predominantly designed for elderly residents, but we quickly realised that actually, you know, there were more people shielding, there were more people who were in need and couldn't get out to get food for themselves because of developing symptoms, etc. So this extended out, and we've worked really well with Stuart's team and schools, also Leslie's team, to make sure that we've got this offer. If we move on to the next one. So what we're now doing and what we've seen is more of a decline in those people who really need that support, although we're still getting practical support calls. But we are providing food now to 150 vulnerable families, and Leslie mentioned some of that. So we're providing a lot of boxes out per week on that basis, as well as providing to households living in temporary accommodation those who were homeless, who we've managed to find accommodation for as well. And we're still getting some urgent calls, some of which are more linked now to finances as opposed to COVID, but we are still getting those through on the shielded list, and we'll be reviewing that along with the shielded list on the 15th of June. We've had some really great feedback on this, and you'll see by the picture at the bottom we've got Councillor Danny Millard there, and that felt like a real achievement actually. That was when we were up to 1,000 boxes. Councillor Millard went and delivered one of those, and you'll see at the bottom that we've actually delivered now 10,239. So there's been a real need there. There is still a real need. There's more demand at the food banks, and we've been helping the food banks get more stocks and providing food for them. And we're also finding that the government parcels, some of those are being received, some of them aren't. There's been some issues about some of them being left in communal areas and flats and not being delivered. I think we've got over that, but we've been topping some of those up as well. So as I say, we're now in a review situation, looking at how we take that forward, but we're finding more people moving on to, and this is a nice segue into Mark's piece, more people are moving on to getting support through the voluntary sector as well, which was part of the plan. So shall we move on to Mark now?
Okay. So the voluntary sector has been extremely busy during this period, and pleasing to say that many voluntary organisations have managed to substantially continue operating and delivering support, albeit in a very much remote and adapted way. Some of the really vital services that are particularly important now around advice, food banks, some of the neighbourhood organisations have continued to operate, and that's made a real difference to people. And obviously many of you will be aware of the mutual aid groups that have sprung up around the country, including Sandwell residents supporting residents. So I think Stuart alluded to it early on his timeline, going back to March. SCU and the council worked together and put out a call really to residents to step forward and to volunteer. We had an absolutely fantastic response. We've had over 700 residents who've come forward wanting to volunteer. I think the figure of those who've been deployed stands at just over 400, so well over half have been busy, have been supporting people. About half of that 400 have been plugged into existing organisations, and the other half have gone towards a couple of new initiatives that have been set up. specifically in response to the COVID-19 situation. I suppose also just to reiterate the point that Stuart made again, that this isn't just those receiving formal shielding. Many people who've been supported by volunteers aren't on the list as such, but are recognised as being very vulnerable, isolated, needing practical or emotional support. One of the things that have been set up, which I think has been really valuable, is something called SAMWELL Together. This has been led by local charity SAMWELL Advocacy. Essentially there to keep people connected. It's a befriending service. It helps people who are socially isolated, including some people in care settings, and it's making the most of volunteers and also staff within that organisation. I know referrals into that are continuing to grow. There's 150 people so far been receiving support through SAMWELL Together, and that potentially gives us a really good legacy as well beyond the current situation, as we know that befriending and isolation are real issues and needs in the borough. In terms of the more practical support, SAMWELL Community Offer, the Better Care Fund team and local voluntary organisations have been very busy supporting people who are particularly vulnerable. We've also initiated a Good Neighbours scheme where many of the volunteers who come through to SCVO have been matched with local people, again offering to do very practical things like shopping, picking up medicines, staying in touch and that kind of thing. In terms of numbers, I think we've seen about 700 people supported through Community Offer, about 300 people through Good Neighbours at the moment. So that's well over 1,000 people when you take SAMWELL Together as well. So it's a fantastic effort. I think we've had really a great partnership working between the voluntary organisations and the council and others, a really strong ethic of working together on that. So a really good result and some fantastic support offered.
That's great. Oh, sorry, anyone else to come in there?
Yeah, just to kind of finish off, Ian. So hopefully the board will appreciate the amount of work that's gone into putting this together, and as Mark said, it's been a real partnership taking it forward. So finally, just really quickly, in relation to next steps, we are going to continue and complete the remaining proactive contacts that I alluded to earlier, and then we're going to focus on those reactive requests from local residents and individuals on our shielding list. The government is reviewing its position on shielding with an expectation that there will be something coming out from government on the 15th of June, so on Monday. In the context of that, the council and its partners will review its approach to shielding and its food offer. And I think as we go forward, we've got to really start to think about how do we promote resilience and independence within that offer. During the initial stages of COVID-19, we very much moved to a protectionist approach. And I think moving as the infection levels drop, obviously subject to potential second waves, we need to start to think about how we work with our voluntary sector partners, as I said, to promote resilience and independence. That's it. Thank you.
Thank you very much, Stuart. It's interesting. You hear lots and lots of things in the press about how much should be being done, and it's absolutely fantastic to see actions being put into words and how much actually really is being done, and it's an absolutely fantastic effort. So first of all, well done. The next thing, of course, it must also be costing a fortune. Maybe work out we've probably spent about £250,000 just sending out letters. And it's interesting that as a Sandwell resident myself, I did get 2 letters, so I did respond. Presumably, I hope that somewhere up above is providing some extra funding to cover all the costs of these. And if either Stuart or David, you're able just hopefully confirm to us that this isn't having to come out of your standard regular income.
David, do you want to answer that?
David's just had to step out of the room, Stuart, if you'd like to.
Yeah. Okay. So if you look at how we've obviously taken this forward, so the council has received 2 lots of funding from the government in the context of COVID-19, and they've contributed to this offer. So they've helped us set up things like the food hub. I think what we've done quite significantly within our offer is make best use of the resources available to us. So there were an array of different council services that had to close. The libraries, as an example, in the context of COVID-19, particularly through the peak of the lockdown. And what we've done quite successfully is redeploy our staff and focus on the skill sets available to us. But wherever possible, we've tried not to incur additional cost. But you quite rightly identified that there are some costs attached to this, but we would be attributing that to the COVID-19 monies that we've had from central government.
That's great. That answers that question. Joanne, you got your hand up. You want to ask a question?
It's not so much of the question, but more than the statement. I'm so proud at this moment in time of what actually Sandwell has achieved. When I ring with somebody in a desperate situation at 9 o'clock and we have a food parcel delivered 15 minutes later, that is an achievement, and I'm certain that the whole team has worked absolutely brilliant.
Thank you.
Thank you, and I would concur. I think it's a question that we really, lots and lots of people really have stepped up to the plate, which is fantastic. Shane, got your hand up?
Sorry, it's David. Shane.
Oh, sorry, right.
No,
okay, David.
Because I was just checking on the IT. Was there a question about costs?
It's been answered, actually. Thank you, David. So yes, there was. It's been successfully answered. I presume that Joanne's had her question answered. I think that what we need to now go is I'd seen a message from Claire, the agenda's been slightly altered, and therefore maybe Lisa, if we go back to you to cover the BAME community, because obviously that is really important, and I can speak from experience. Not only do we have a lot of residents who are in that community, always a lot of background noise, but also we have the challenge that amongst our Sandwell general practitioner population, 25% of our general practitioner population themselves are over 70, the majority of whom are in the BAME community. So it's not just a question of our patients, it's actually our health resource. So Lisa, update on BMAE. You're on mute, Lisa. You're on mute.
I knew that. I was just testing you. Thank you, Dr. White.
It's Lisa.
So just going to share my screen. Where are we? So hopefully you can see those slides.
I can certainly see them, yes.
Okay. So, Dr. Sykes, I'll just very briefly, because I don't want this necessarily to be bogged down with data. Data is only a small part of it, but it really is worth us considering, I suppose, where we are in terms of the facts around BAME groups, Black and Asian minority ethnic groups, and death rates. So I'm just going to show a few slides that really are some of the most stark slides I've seen in a long time. They come from the ONS. So again, the most comprehensive data that we have on COVID-19 deaths. And what that chart shows you is the comparison group, if you like, here is white British. And it shows you how many times more likely each group is, according to the data, to have died from COVID-19. Now, importantly, this first graph, I've got one for women and one for men. Importantly, this first graph is adjusted for age. And you can see there at the top, the Black group is more than 4 times more likely to have died than white British. Also, we have people in the Bangladeshi and Pakistani group who are more than 3 times as likely to have died from COVID-19. That's the situation for women, and we see a similar picture for men. You can see again, Black men more than 4 times more likely to have died. Bangladeshi and Pakistani men between 3 and 4 times more likely to have died. It's quite a crude analysis because, of course, ethnicity there are more groups than are shown on this graph. Statistically, the numbers wouldn't necessarily allow more detailed analysis, but it certainly makes the point that there is a stark inequality there. Now, these graphs have been adjusted for age. Of course, what we know about COVID-19, and probably didn't surprise us that much, is that there are inequalities also in relation to deprivation. What this graph shows is the percent more likely someone will have been to have died depending on their deprivation group. So on the right-hand side is the most deprived groups. And on the left, right over to number 10 on the left, is the most affluent, the least deprived group. And I suppose that's our comparator. And you can see the deprivation, that there's a linear relationship there between socioeconomic deprivation and likelihood of dying from COVID-19. Much more, in fact, than there is for even all-cause deaths. So taking that into account, what happens when we enter that into the frame, when we consider the effect of BAME on death rates? So you can see this time now we've adjusted for age and also socioeconomic deprivation. And what the ONS did here is they used the indices of multiple deprivation, and they've adjusted the analysis to take account of the effect of those indices of multiple deprivation. And you can see that the excess mortality has dropped. So, for example, for women now, it's less than 2 times as likely. For Bangladeshi and Pakistani women, it's 1.5, maybe approaching 2 times as likely as well. And for men, again, a similar picture. So there's a couple of points to make about that. So what we're saying there is at least half of the excess mortality in BAME groups is accounted for by inequalities in socio-economic status. Of course, the indices of multiple deprivation, for those of you who are familiar with them, don't include all socio-economic factors that may be relevant here. There's 3 that we've picked out that are particularly important that were not accounted for in that analysis. Occupation. So you made reference there, Dr. Sykes, to how so many of our health professionals, doctors, nurses, care workers, are from BAME backgrounds. Also, of course, we know multi-generational households are more likely for some BAME groups, and also often those groups will live in more dense population areas across the country anyway. So there's a lot more to be accounted for. So essentially the conclusion on the data is that, yes, there is a lot of excess mortality in especially Black and Asian groups. The majority of this can be accounted for by socioeconomic factors, and we expect occupation and multi-generational households to also account for extra differences. But there's 2 things there about that. Firstly, it doesn't account for all the difference. And also, we have to be really careful in how we tell this story. Because when someone like me says that if we account for socioeconomic deprivation, it reduces the excess mortality, it doesn't reduce it, it explains it. But to actually then conclude, oh, well, that's okay then, is of course to miss the point that what COVID has done here, whether it be in economic deprivation per se, or in terms of BAME inequalities, is COVID has shined a light on those inequalities like never before. And they are left in sharp focus. And, you know, if we didn't think they were a priority before, then we certainly know that we need to address them now. COVID-19 is discriminatory. There was a lot of narrative at the start of the pandemic with people saying COVID-19 doesn't discriminate because the Prime Minister's got it. Well, yes, it does. It discriminates a lot. Just to make the point that that was national data I was showing you, but excuse me, data from our colleagues in Sandwell West Birmingham Hospital Trust, which is fairly hot off the press, shows that certainly in terms of the Black, African and Caribbean group, there are again higher mortality rates. Those figures there are adjusted for population, so it takes into account how many people in our local population belong to those different categories. So that's accounted for. It's relatively small numbers statistically speaking. So the actual numbers that is based on is 299, and for example, in the Black group, there's 19 deaths. So we have to be a bit careful statistically with local data, but I think it's safe to say that certainly in terms of Black and African groups, it's following the trend. And the thing about the Asian group there is, unfortunately, the local data lumps Indian in with Bangladeshi and Pakistani, and obviously there are different socioeconomic factors there in those communities. And I just want to end, Dr. Sykes, with, I said at the start, we have to consider the data, but the data won't really get us anywhere. So what we did in preparation for this board meeting was some of my team got on the phones and started talking to some of the people actually we've already spoken to about this issue on numerous occasions, just to get their comments. And I won't take up the board's time going through them all now. But what you'll see in the comments when they're disseminated is some really important themes. The people who have responded are, for example, Inam Chair, the West Bromwich African Caribbean Resource Centre, the Yemeni Community Association, and many others. And they talk a lot about fear. They talk a lot about anxiety. They talk a lot about how, as I just said, if this doesn't make us address inequality, what will? And that we need to have that conversation urgently about what we're going to do about this. They also talk really interestingly about the fine line that exists sometimes between protection and discrimination. So, for example, when I was talking to the head teachers doing all those risk assessments over the last few weeks, one thing that kept on coming up was, you know, what would it look like? How would it feel if we said, okay, children from a BAME background couldn't come to school? This school was now only for white British people. That would obviously be a retrograde step. So there is a fine line, I think, and the communities are aware of this, between protection and discrimination, which makes it all the more important to do something. I hope that we do very well in Sandwell, and something I've talked about in other areas of public health in terms of the Stronger Sandwell approach, is whatever we do around this, we need to do it with people and not to them. We need to involve people in the decision making and thought process, and not just make proclamations, I suppose, on the basis of a bar chart. So I'll leave it there. I will unshare my screen, hopefully. And hopefully you're back.
That's really helpful, Lisa. I mean, it's not really, I suppose, for discussion. I'm aware that time is tight. I think it just provides food for thought. I know that a huge amount of work is being done both within the local authority and in the CCG to try and address those factors as much as possible. I know a lot of work has been done in Birmingham along with Justin Varney. So I think what it has highlighted is, first of all, that we are now fully aware of those problems and people are working very hard to try and address them. But we need to make sure it doesn't slip down our agenda. So thank you very much for that. I am aware that we are running a bit behind time. I apologise for that. We have covered shielding, so I think it's Care Act easement. It's Stuart and Rachel. Are you there to give us an update on that?
Yes, thank you. I'll just share my screen, and then Rachel will take you through the kind of first slides, and I'll just do a bit of a summary at the end.
Okay, thank you. We'll try and keep it as brief as we possibly can. Rachel, you're frozen.
Yeah, my screen doesn't work very well on Microsoft Teams, unfortunately.
Okay, have you got any slides you need to show? Or
Stuart's getting the slides.
Okay, that's fine. So Stuart does the slides. If you're able to talk to them, that'd be great, Rachel.
Yeah, no problem. Okay.
Okay, we've got the slides. Is Rachel able to talk to them?
Just start on the second one, Stuart. Can't see that one.
Can people see those?
It's on slide 5 at the moment, Stuart. I think, did Rachel want to go to slide 2?
Please.
I think we're having some technical difficulties. So on my screen, it's that I'm on slide 2.
Okay, well, okay, I can't, yeah. So basically, it's an overview of the Care Act easements and where Sandwell are in relation to Care Act easements. So probably many of you will be aware that the Coronavirus Act 2020 has brought into effect Care Act easements, and they're there for local authorities to enact in the event that our workforce is significantly depleted or the demand on our social care is no longer reasonably practicable to comply with our Care Act duties. Samwell have a number of tracking reports in place to monitor this. So we're monitoring staffing levels, and currently staffing levels are high in Samwell in adult social care. It's very positive. We're also monitoring the demand on provider services. We have a daily snapshot of care homes and domiciliary care. This is not only to monitor the potential impact and demand it could place on adult social care, but also in place to support care homes and domiciliary care. We also have daily sit-rep meetings across the week, and they take place with directors and service managers. And that kind of informs us of new information coming through. We're doing our risk assessments and also for future planning. So there are 4 stages to the easements. I wanted to start by talking about stages 3 and 4. And this would mean that we have moved into operating under Care Act easements as outlaid in the Coronavirus Act.
You're frozen, I'm afraid, Rachel. We can't hear you. Are you still there, Rachel? Okay, looks like Rachel may have disappeared. Stuart, are you there?
Yeah.
Is it worth you taking over and going through the slides, and maybe if Rachel gets back into us, she can always...
Yeah, I'll take that. I'm not going to do the slides. I'm just going to talk you through the kind of ins and outs. So as Rachel mentioned, there are 4 levels to Care Act easements. The big Care Act easement is at level 3. And at level 3, that's where the local authority will be looking to reduce its activity in relation to its statutory functions under the Care Act. That would mean that we wouldn't be doing full assessments and support plans. It would mean that we are doing a really low-level proportionate approach. And that would be in the context of us having significantly depleted workforce, or there being a massive demand for adult social care. So we've not hit that level. So at the moment, we're still at level 2. Level 2 is in Care Act easements is about the use of kind of digital technology and things like telephone reviews, but still working within our established legal Care Act framework. There are, I think, 8 authorities across the country who have implemented Care Act easements at level 3. When you implement at level 3, you have to notify the Department of Health and Social Care. The 8 authorities who have implemented those easements at level 3 have received quite a lot of criticism in the context of whether they did that too soon. But as I've mentioned, in Samwell at the moment, we've not hit that level of reduction in our workforce or demand for social care that has had to inform the decision to look at level 3 easements. Going forward with Care Act easements, obviously we're going to continue to monitor the position around the workforce within adult social care and the demand for our services. There are a number of things that will potentially trigger a level 3 response. So we've alluded to already 2 of those in the context of the implications of test and trace, and also a second wave. But for now, we're at level 2. We will continue to engage the Cabinet Member for Healthy Lives and provide further updates to the Health and Wellbeing Board in the context of our current demand for adult social care. But at the moment, we haven't had to deviate from our legislation. One thing to kind of finally say, in and amongst the Care Act easement, there's no easement to local authority and its partners' responsibilities for safeguarding adults. So while that has continued, there's no easements in relation to our responsibilities to promote people's human rights. Originally, there was some amendments proposed to the Mental Health Act. However, those amendments never received royal assent, and as such, we're still working to the Mental Health Act as it stood before COVID-19. So that's the position on this. Apologies for the technical difficulties.
Well, that's really helpful. Thank you, Stuart. And I think it's very reassuring to the whole Health Wellbeing Board that actually our Care Act work is still proceeding, and is still proceeding as normal as it possibly could do under these very difficult circumstances. So thank you for that brief update. Appreciate it's difficult with the technical. I'm going to move us on now. Next on the slightly altered agenda, it's children's schools. So over to Leslie to introduce this. Leslie, I know you've given us a little bit of update, but this is item particularly on children's schools regarding COVID. Can I hand over to you with input here from Chris Ward and Francis Craven?
Thank you, Ian. I'll share my screen, and we've got. We're going to try and stick really well to time. We've got a few minutes each. Can you see my screen?
At the moment, I can only see you. Can't see anything else on your screen at the moment, I'm afraid, Leslie.
Right. Okay, I'm sorry. So if I start talking, and I'll try and share my screen as I go at the same time. I'm just going to give a broad overview about some of the really fantastic partnership work that's been happening during this lockdown period. And I wanted to talk very quickly about two things specifically. One which is around the importance of communication and information sharing, and then secondly about vulnerable children. So whilst within each agency, obviously everyone's been having their daily meetings to share information. In the council, we've included Sandwell Children's Trust in those meetings, but we've also had a weekly partnership meeting for the partners involved in the Safeguarding Partnership, Children's Safeguarding Partnership. And I've been so impressed by the way that everyone's come together. It's a big ask at the moment to ask people to give up an hour every week to come to a meeting, but all partners, all parts of health, from primary health through to specialist services, police, neighbourhood police, as well as child abuse investigation unit, the voluntary sector, the Children's Trust, and education and local authority services meeting together once a week to share business continuity plans, think about how those plans impact each other's work, and really make sure that nothing falls through the gap, that our services are still really joined up, and that we can support each other to make sure that children are particularly safeguarded at this time. There have also been, for the local authority, weekly meetings, or 3 times a week sometimes, meetings with the DfE and Ofsted. They've been tracking everything that we've been doing at a local level very, very carefully, and feeding that into regional and national work. And as part of all of this, we've tried as much as possible to still interact with children, young people and families to make sure that children are seen, and that we hear children and young people, and we understand their experiences and the experiences of families. The communication at all levels has been a thread running through all of this work. For vulnerable children specifically, we've run a number of campaigns, online safety, home safety, access to encouraging families still to access universal services with GPs and A&E. There is a vulnerable children group meeting, which I mentioned earlier when talking about shielded children, just making sure that all children in Sandwell that are considered to be vulnerable, and this is a large number of children, that someone is making sure that contact is made, and that the appropriate professional is in contact with that family. And we've been sending the information from that meeting to GPs as well, where we think they need to be alerted to concerns. Our detached youth work has continued, and that's also enabled us to stay in touch with young people, vulnerable older young people, as they're hanging around in parks or on the streets, etc. And through all of this work, we've created the bones of a surge plan that we're now moving into a recovery plan. What we've identified today, actually, at that meeting, is that there probably isn't a partnership need around surge, but there certainly is around our joint commissioning for certain services, particularly when we're thinking about emotional health and wellbeing for children, domestic abuse, and some other pressures. I'm going to hand over to Chris, and I'm still trying to share the slides, and my apologies. Chris.
It's okay, Claire's put the slides up, I think, for us on this one.
Oh, great.
Okay, evening all. It's a very busy time in education at the moment. This week does seem to be Education Week. We've got a lot of range of different settings open and academies as well we're working with. So trying to get everybody to stay in step is the real key, so the local authority has one response to this. If I start with early learning and childcare arrangements, when we initially went into lockdown, it's cut down about a quarter of all of the provision, because the number of people involved in being a critical worker or having vulnerable children reduced the amount going into early learning centres and settings. This has increased since June the 1st, and it's doubled. So we're up to about 50% of those open and 50% of our childminders. So we are seeing a steady increase now of people starting to take on the resource that's available. However, there is a worry within that some settings are finding it difficult to keep their businesses running. Our schools throughout all of this, as you know, have remained open to all vulnerable children and key worker children. Sorry, if you can hear a dog whinging in the background, it's my dog at the side here, sorry about that. And they have been supporting all pupils who are not able to come into school through online learning or through the learning packs. And as Leslie mentioned earlier, we're also supporting that as well, where necessary. Now, the schools are moving into this phase of wider opening, and when you count the vulnerable children and critical worker children, we only had about 2% of the population of children in schools. That's increasing slowly. It's gone up to 6% now with a wider opening. On Monday, we'll see Year 10 and Year 12 children starting to come into our secondary schools, so that'll push that up further. So it's a very gradual increase, which is being driven by schools and their governing bodies, making decisions about how much space they've got, can they keep social distancing. So the key issues for schools have been about how do they do risk assessments, particularly with social distancing in mind, keeping children in bubbles, making sure they make good decisions around how they use PPE and the practical and logistical arrangements with that. Transport is going to be an issue, particularly for our special needs pupils, because social distancing means we can't put as many on the buses, which will increase the costs we have around transport for those young children. So the issue for schools is they're dealing with ever-changing and developing guidance, as it says here. Leslie and I were counting up the numbers of guidance for children's services, and we've had about 151 apparently since this started, which is an awful lot of guidance to take on. And of course, every piece of guidance has to be interpreted into how it works in schools. So the council has been trying to coordinate all of this and supporting children throughout the process with the schools. So we were doing the play at home and looking at how we can support them with their learning through IT. And part of that work has been to work directly with the trust to identify children in care who will receive a laptop from the government. We've had 1,800 of them delivered to us. Just over 1,500 are going to children in care, and the rest are going to Year 10 pupils, and we've started distribution of those today. So there's quite a lot of additional IT systems going in for young people. That doesn't provide every child with one who would be eligible, but we're trying to get a balance right between those who receive them in a family, so they get them as a group of children to be able to access it. Obviously, schools and children in particular, young people, are very concerned about their examinations and their assessment, and schools themselves have had to go through many systems of ranking pupils in terms of their performance based on their position when education formally stopped in its normal sense. And that's being submitted now. Now, quite clearly, there'll be a group of young people who get the grades they wish for and some who won't. And we know that exam boards are putting on retakes in the autumn, and people will be putting in support for young people to get them to that point where they can take the exam again. So for us and the council, we've had to adapt a load of our services, majorly moving those things to online services and the use of Teams, as we are doing here now. A bit of statute has changed to enable us to do things like admissions online and appeals online, which has really helped us to move things through. And the big risks for us and the assumptions that we've got seen in here, we will be seeing an increase in elective home education. That's been steadily increasing anyway in the borough, but we believe that the experience through COVID-19 will make more people wish to opt for elective home education. And we're going to have to increase our resource to meet that. We also know that our team working with the educational psychologists will get a lot of requests from school to increase support for children who've got anxiety or school refusal issues. It's quite key that we support them to go back into school so they feel comfortable, and the curriculum that schools are going to be putting in place to assist that is going to be critical to make sure they make a good transition back into school. Overall, it's the widening of attainment gap that you might see. At the moment, we know that young people have missed 8 weeks of schooling out of the 10 weeks with the lockdown, which makes a big difference then going forward. But it's something our schools are very mindful of, especially if children are at a transition age and moving from primary to secondary, and we're looking at ways in which we can support them with their learning to make that a smooth transition. That's it from me, so I'm going to hand over to Francis.
Thanks, Chris. Just an update from the Trust. So we adopted a set of principles quite early on, which was about being child-centred and making sure that we kept children right at the forefront of our decision making, but also putting in place things to do with risk-based assessment around things and evidence. But the key thing that Leslie referred to was about partnership working and being collaborative and transparent. The Trust has had a robust leadership and governance processes in place and has been linked in very much with the partners through the safeguarding partnership that Leslie chairs, and also with the council, and that's been really, really helpful to the Trust. We have had to make changes to core practice. The majority of our workforce is working at home. We have a number of staff, though, at the front door and in the MASH. We've had to put in place pre-visit risk assessments to determine whether visits can take place, what type of visit that might be, taking into account social distancing, and also whether there's a need for PPE. We've adopted virtual visiting mechanisms and ways of recording that. So as a result of that, we've got increased management oversight. We have COVID-19 management decision making on the system, which shows us why there's been a rationale for not a face-to-face visit and why that's being done virtually. We've identified our most vulnerable groups within our already existing vulnerable groups, and we have daily dashboards, and those are interrogated by teams. So that so that children do not fall through the net. And it also links across to the work that Leslie was talking about in terms of the vulnerable groups and people sharing information. One of the things that really stands out for me has been the enhanced opportunities about partnership working, and the partnership working has been really very much strengthened. We've got a lot of work going on through our participation team, supporting care leavers and some of our vulnerable groups that are looked after. And again, that's being done in conjunction with the council. Relationships with partners, it's already been mentioned about sharing vulnerable lists, practical support around food for our vulnerable groups, particularly our care leavers, sharing attendance information. There's been new information and guidance that's come from central government, which has been about social workers, every social worker having a conversation with families and foster carers about attending school. And we've had to develop systems for recording that so that we can actually measure that that's happening. And of course, work around shielding and laptops. In terms of performance, I think one of the big risks and challenges that we've talked about as a partnership is about hidden risk. We've seen a drop in our face-to-face contact with families, but we've obviously seen that increase in virtual visits. Those are looked at on, as I said, a daily basis, but we've enhanced our performance processes. So we have a weekly performance board that dip samples those cases and actually looks at performance and looks at where there may be any gaps or risk. Initially, we saw a reduction in contacts and referrals at the front door, about 15 to 20% reduction. That is now steadily increasing. It's not quite back where it was, but there are, we've got some significant concerns about when schools are fully back and about the increase in referrals because of vulnerabilities that are identified when children return to school. And we're doing lots of planning around that and scenario planning and how we will manage that. There's been a slight increase in domestic violence, and I think what we need to do as a partnership is actually look at that over time, because you can see some variability in between weeks and days in terms of whether it's up or down. The thing that we're doing at the moment now is we're looking at our recovery, at reset, what that's going to look like, what the new normals look like. We've done quite a lot of work about looking at the strengths that have come out of this situation, about how we've been working, but also looked at those weaknesses around it and looking at the opportunities. As people are aware that the trust is has been under great scrutiny from external regulators, and there's discussions going on with Ofsted about the new assurance visits that they're going to be doing to local authorities, or with local authorities, starting in September. And obviously, I think we're in a good position because of the work that's gone on amongst us in the trust and with partners to welcome Ofsted to come and look at some of that work that's been going on. So I shall pause there. I could say an awful lot more, as I'm sure we all could, but I know we're short of time.
Okay, thank you very much. That is very helpful. I think it's important that amongst the COVID, it's been very easy to think about it all being adult, older people related. And I think what it shows is this has actually had a big impact on our families and younger people. And it's very reassuring, hopefully, for the board to realise just how much work, fantastic work is being done to help protect our children and families. So thank you for that. In the nature of time, I certainly don't want to stifle debate, but I'm going to suggest we don't take any questions on this. If you've got any particular comments, can I suggest that you direct them to, if I can take the liberty of directing you to Leslie, or if necessary Claire. Thanks, Leslie. So direct any comments to Leslie. Leslie will feed them around the group as appropriate. So thank you very much for that reassurance. That now takes us on to care home update, which we're a bit behind time. However, these are really important things to address and hopefully reassure the board how seriously we are taking the COVID crisis. So Stuart, anything more you want to say on care homes?
So I'm conscious of time, Chair, so I'm not going to put my presentation up. I'm just going to talk you through some kind of snippets, really. So people will have seen on the news there's considerable national concern around COVID-19 in care homes, and it's been mentioned on a number of occasions through the board's presentations today. So in Sandwell, there are 83 CQC registered residential and nursing homes. That provides 2,203 registered placement people. The care homes that obviously we have in the borough, similar to everybody else, support some of our most vulnerable people within our communities, and as such, you can automatically understand why COVID-19 would be such a significant issue for those homes. So in Sandwell, I think we've alluded to that we have seen outbreaks in homes. So 37 of our 83 homes have had levels of infection within them. We've seen 41 people die of COVID-19 in our care homes, but as Lisa kind of took you through, that's lower than the regional and England averages. From a support to care homes perspective, we have daily market oversight and a same-day response. So our providers do a return that tells us how they're getting on in regards to PPE, their staffing levels, whether they've had any outbreaks, their financial sustainability, and their overall vacancies. And I'll come to that in a moment. Our colleagues in public health have done a really sterling job supporting our homes around infection control and outbreaks. We've also had considerable amounts of testing supported by Toby's teams and our CCG colleagues. And that's included staff testing within our homes alongside proactive